Hello, I'm Daniel Chiche, and I'm very pleased to discuss with you the future and how we could use artificial intelligence to predict major complications in the ICU. When we speak about artificial intelligence, we have to remember the pioneers of computer science. And I believe that when Steve Jobs and his colleagues introduced the Macintosh, they did not think that today we would be discussing the digital transformation of the society and that this would foster the advance of artificial intelligence and machine learning. If you look at the hype cycle, the Gartner hype cycle, and see where artificial intelligence lies today in this hype cycle, you can see that roughly it's still in the uh, um, innovation trigger and did not yet reach the peak of inflated expectation. And before it actually reach the plateau of productivity, we can expect that it's going to take some time. But still, we can start to think about how we could use artificial intelligence to help us to become better doctors because we would be able to focus on the important issues. Indeed, in the ICU, can you think that we are going to be able to interpret or integrate multiple clinical information, biological signals, so that we can actually make accurate risk assessment? This is coming to us already, and the issue of precision medicine has entered into the era of big data. And it's no wonder that we see this already happening in precision oncology, for instance. In oncology, when you gather molecular data, clinical variables, some demographic information, and put this in a knowledge bank, use some predictive modeling, you can start to make decisions for an individual patient and consider the risk of complications such as relapse after bone marrow transplantation or even clinical complication. Can we do this at the bedside for patients that come to the emergency room or the ICU? We are starting to see some interesting papers where, for instance, they focus in this paper on our ability to detect cardiac arrest and respiratory failure requiring intubation using artificial intelligence with quite simple trajectories of patient data. They looked at vital signs that we measure every day: pulse rate, blood pressure, respiratory rate, SpO2, body temperature, whether there's treatment history, the classification of the patient in terms of ASA classification, and whether the patient is a surgical patient or not. You can see that here we are focusing on events that are going to happen in the very first hours after admission. And as compared to a dichotomous evaluation of these parameters, when you use artificial intelligence and continuous patient monitoring, as compared to scoring systems such as Muse and Use that have been used with success in the emergency department, you significantly increase our ability to predict major complications such as acute respiratory failure or cardiac arrest. At the same time, when you think artificial intelligence, you think imaging because this has clearly empowered radiologists to go with better diagnostics quicker. And this is becoming today, I would say, almost a gold standard. We also have images in the ICU. For instance, each time we look at a ventilator, we can look at waveform tracings, and AI today can be used to identify patient ventilator asynchronous. We all know that it's quite difficult to do and to teach to residents and fellows. And today it's quite interesting to see algorithms that predict double triggering, flow limitation, ineffective triggering with quite good accuracy and sensitivity and specificity as compared to what we could do at the bedside. Using a hidden Markov model technique in this paper, they've looked at many patients, more than 10 million breaths, and identified that the frequency and duration of hypoxemia episodes were higher in the period of time with frequent asynchrony. And here again, they could predict patient ventilator asynchrony with quite reasonable accuracy in these patients, and were able to detect this episode of hypoxemia. This is quite important because we've known that asynchrony can be linked with the development of patient self-inflicted lung injury. Now I would like to switch gear and look at another potentially important complication, which is to look at acute kidney injury. We know that acute kidney injury is a widespread, often unanticipated event with high death rate. In our ICUs, for instance, when I was in Paris, we used to treat roughly 1,600 patients a year. One third with AKI and mortality would raise to 20%, and 1/6 with severe AKI with an even higher mortality. Quite interestingly, 35% of all AKI episodes were not anticipated. And it's actually no wonder, because when you consider the pathophysiology of AKI, it's quite a multifactorial and heterogeneous condition. We have different pathogenesis mechanisms, different causes such as sepsis, vasculitis, acute interstitial nephritis, toxicity of drugs, and we have AKI with different severities. It would be quite interesting to be able to develop acute kidney injury prediction models that would consider medical history of the patients, preconditional AKI risk prediction, conditions when they are in the ICU that increase the risk of AKI, and look at the response, the trajectory of the patient in response to treatment to have a much better assessment of who is going to develop AKI or not. In the ICU, we are in a unique environment to do this because we can actually access 6,000 to 8,000 data points per time and per day, and that can help us build these algorithm, the type of algorithm that you would like to have to clearly see that these patients that you have in front of you has a sudden increase in the risk of developing AKI, and that this may actually need some, I would say, action. Machine learning has been used to develop in-patient AKI prediction models. And in this interesting study published by Matt Sharp's group, looking at data from more than 120,000 patients, using gradient boosting machine algorithm, they've been able to identify an AKI prediction model that reached quite interesting prediction capabilities with a area under the curve roughly of 0.787. In the development of this inpatient AKI prediction model, you can see that the variable that had the most weight in the AKI prediction model were the changes in serum creatinine, ICU length of stay, the PaO2 FiO2 ratio, and obviously the changes in urea and urine output. It's interesting because these are a variable that we as clinicians consider as obviously important, that makes sense. Looking at the different probability cutoff and the accuracy of the test, we can see that at a probability threshold of 0.022, the algorithm predicted the development of stage 2 AKI with a median anticipation of 41 hours. With colleagues from the Boston Consulting Group, we looked at the risk of AKI and AKI-related mortality in ICU patients also, and built a model that identified 82% of AKI patients while raising at most 3 false alarms out of 10. And this has been also confirmed in 2 validation cohorts. We then performed a clinical study, then compared the ability of the algorithm to what doctors actually do. And as compared to physicians, the model identified 85% of AKI within 48 hours versus 51% for the doctors. You would not think that parameters such as heart rate variability during the nighttime would have an importance. That's the thing that only artificial intelligence would point out. Google has actually performed this study with the NHS, and in this study published in Nature, looking at 700,000 patients, they used a recurrent neural network also to build an AKI prediction model. And they built a model that would predict 55% of all inpatient episodes of AKI and 90% of AKI episodes that require dialysis with a lead-up time of roughly 48 hours and the ratio of 2 false alarms for every true alert. This got a lot of publicity as this DeepMind Streams app was also associated with a decrease in cost around £2,000 per patient. Obviously, we have to take this with a lot of caution and remember that when you're looking at artificial intelligence algorithms, the past is not always useful to predict the futures, as machines can only learn from what has happened. Obviously, research based on big data does not provide strong, if any, causal inference. And obviously, if we use this system improperly, they can replicate bad practice as compared to improve them. Finally, we also have to consider the fact that the data is compartmentalized, sometimes corrupted. The quality of data may be an issue, and the complexity of data is also important. But undoubtedly, we are entered a field where digital health is going to change, and that by combination of data coming from very different biological omics and also environmental database, we will be able to improve our ability to recognize conditions, predict complication, and improve the way we care for patients with much more precision than we have today. I'd like to thank you very much for your attention.